Thank you very much for the presentation. Dear chairpersons, dear colleagues and friends, it's a pleasure to be here today with all of you. My name is Pedro Lopez Ayala. I'm a fourth-year PhD student, and in the next 10 minutes I will be talking about the direct comparison of cardiac myosin-binding protein C, CEMIC, versus high-sensitivity cardiac troponin in the early diagnosis of acute myocardial infarction. So, cardiac troponin, you are all well aware of it. Many of us, we love this biomarker. And just very briefly, the fourth universal definition of myocardial infarction is heavily dependent on cardiac troponin. It's one of the three main diagnostic pillars for the early diagnosis of acute myocardial infarction. It has been, or at least high-sensitivity assays have been available for over a decade. And during all this time, no single biomarker has been able to beat high-sensitivity cardiac troponin for the early diagnosis of acute myocardial infarction. It is unbeaten to date. So before going further, the million-dollar question that I would like to ask you is, does anyone think there is a biomarker that can compete against troponin in its own home ground? So that's for the early diagnosis of acute myocardial infarction. Anyone? Any brave researcher? None? Yeah. So that same reaction was mine more or less 1 year ago when Christian was proposing suggesting this analysis, but nevertheless, we carried it forward. So briefly, cardiac myosin-binding protein C, it's a cardiac sarcomeric protein, which is associated to actin and myosin. It was discovered, identified 10 years ago, and as you can see in the figure, it is released to the bloodstream together with cardiac troponin after ischemic cardiomyocytes, after necrosis. Now, several basic studies have shown that it has a different kinetic profile to troponin, and it seems that the concentration rises more rapidly. And just recently, a new immunoassay on a large automatic platform was established. Therefore, our aim was to compare this novel biomarker, CEMIC, with our best-in-class biomarkers, troponin T and troponin I, for the early diagnosis of acute myocardial infarction in patients presenting to the emergency department with chest pain. So for this endeavor, we used the APACE study, which has already been introduced. Very briefly, chest pain patients presenting to the ED were recruited into the APACE study, which is a prospective international multicenter diagnostic study. Serial blood samples were taken, troponin was measured, and for this analysis, 0-hour troponin T, Alexis, 0 hours troponin I, Architect, and 0 hours baseline CEMIC were measured. For the central diagnostic adjudication, all available medical records together with cardiac imaging, troponin, 90 days follow-up were used and were assessed by 2 independent cardiologists using the fourth universal definition of myocardial infarction. Very importantly to remark, both cardiologists were blinded to the CEMIC data, and I can assure you this because the data of CEMIC was not available at the time the central diagnostic adjudication was performed. So, 2 gold standard diagnoses, one including troponin T, high sensitivity cardiac troponin T, and the second one including high sensitivity cardiac troponin I. The primary diagnostic endpoint was index and STEMI upon presentation to the ED, and type 1 or type 2. We did a subgroup analysis in age, sex, early presenters defined as less than 3 hours, less equal than 3 hours, very early presenters, less than 2 hours, recall the kinetic profile, and as well as glomerular filtration rate. And finally, we also assessed prognostic endpoints, 2 years, all-cause death, and cardiovascular death. So to the results, a total of 4,755 patients met all criteria. That means that they all had a baseline CEMIC, troponin T, and troponin I measurement. STEMI patients were excluded. And as you can see, chest pain characteristics are very common of a chest pain cohort with a median age of 60, 33% of female, 37% of early presenters, less than 3 hours, so on and so forth. So to the first results, we're going in the good direction. As you can see, in patients with myocardial infarction, THEMIC was much higher than in patients with other diagnoses. Now, the big question, right? The comparison and the discrimination against these two tough guys, troponin T and troponin I. So red is THEMIC, blue is troponin T, green is troponin I architect. So we first start with the gold standard using or including troponin T. And what are the results? THEMIC has an area under the curve of 0.943 compared to troponin T of 0.936 and I 0.927. And yes, this was statistically significant. It was higher, the diagnostic performance for THEMIC, and it was significant. Now for troponin I, so it's the gold standard, including troponin I measurements. Again, THEMIC was higher than troponin T and higher than troponin I. And this was also statistically significant. So to the subgroup analysis, you can see in patients that are older, THEMIC was higher than T and I. But the three main subgroups that I would like to draw your attention are the early presenters with 0.94 for THEMIC. Very early presenters still continuing the discrimination keeps the same for THEMIC, while for T and I has reduced a little bit in very early presenters, and also glomerular filtration rate. You can see that it is also higher in THEMIC. Now the added value, for those of you that still are not completely convinced, right? I mean, we're just comparing troponin T to THEMIC, troponin I to THEMIC, so it's just one-to-one. But we usually use biomarkers together with clinical characteristics with the ECG, so it would not be a fair head-to-head comparison. We want to see if it adds value in a clinical setting. So we fitted a base model including age, sex, glomerular filtration rate, high sensitivity cardiac troponin, time since chest pain onset. We know that these are common confounders of troponin, and also the ECG. Importantly, also continuous variables were assessed with restricted cubic splines, allowing for even better performance. And the extended model is the base model plus our new biomarker, THEMIC. So last chance for troponin not being beaten by THEMIC. And what did we find? Well, we found that the base model is very good, 0.943, but the model with extended model with THEMIC, it's even better. It's 0.95, p-value was significant. You can see other statistics like the archaic information criterion. The lower the better. We can see that it is lower for the extended model. The likelihood ratio in this case is the opposite way. The higher the better, also significant. And the fraction of new information, kind of a new statistic. The fraction of new information, basically it's just telling you the added predictive information provided by the new biomarker on top of the base model. Now we have a base model that it's a very strong base model, right? It's adjusting for all previous important information. That was for gold standard, let's call it T, with including troponin T. What about I? Well, again, base model 0.948, very strong base model, but with THEMIC it's even larger, it's 0.96. And the same for the fraction of information, 8.7% of added value. It's a relative performance. So that was me changing sides to the THEMIC team and my happy face. So now to the prognosis, all-cause death and cardiovascular death to 2 years. And we can see that THEMIC and troponin T have the same prognostic performance. And compared to I architect, it was higher for THEMIC and for troponin T. So some limitations that merit consideration. First of all, it was conducted in needy patients. We cannot comment on the performance in other clinical settings. Again, we cannot generalize our findings to patients with kidney failure. That would be requiring dialysis, but it would be very interesting seeing the subgroup analysis. This is very important. And high sensitivity cardiac troponin is not just a comparator. It also, to some extent, is the referee, because the diagnostic adjudication of acute myocardial infarction in the fourth universal definition of myocardial infarction is heavily reliant on it. And despite this, THEMIC was able to show a higher diagnostic performance. And finally, it is a diagnostic study. We cannot quantify the possible improvement achieved in clinical care. It is statistically significant, but whether it would improve clinics. That is something yet to be determined. So dear chairpersons, dear colleagues, to conclude, cardiac myosin binding protein C has a superior diagnostic accuracy shown for the first time compared to troponin T and I architect for the early diagnosis of acute myocardial infarction. The diagnostic accuracy was superior in early presenters, very early presenters, and with low GFR. The MIG was able to add diagnostic value on top of a strong diagnostic model which adequately adjusted for prior information. However, the gain is statistically significant. Is it clinically significant? That is yet to be determined with implementation studies. And the prognostic accuracy was comparable to T and superior to I architect. With this, I would like to thank you all. I'm looking forward to the discussion. I would also like to thank the CRIP. That was when I started 2009, and this is just recently. Thank you very much.
Thank you, Pedro, for this presentation. Now it's open for questions.
Thank you very much, Pedro. A very excellent presentation. So where do you think might CMIC be useful in clinical practice? Is it more the rule-out side? Can we further improve the rule-out? Is it more the rule-in to identify high-risk patients and patients with non-STEMIs?
Thank you for the excellent question, Jasper. So, I mean, we have seen that it has shown up, and probably that's being driven, the higher accuracy is because of the early presenters, right, in that range of 0, 1, 2 hours in chest pain onset. So most probably I would say in this setting it could add value on top of troponin, and basically for rule out, for allowing a very quick rule out with a first blood determination. In patients presenting with chest pain less than 2-3 hours, the EST01 algorithm and also the high-stakes pathway, they cannot exclude patients directly. You need to wait and you need to test a second one. So in these patients, the MIG could allow it because it doesn't have, because of the kinetic profile, it doesn't have, let's say, this limitation that troponin has.
Thank you. Great presentation. I mean, I've got the Team Troponin shirt on as well. I'd be interested, if I understand correctly, these area under the curve plots are based on the first sample presentation. How do the two compare if you look at later time points? Because that will help you get to the bottom of the why issue. Is it to do with the release or the kinetics and time or not? Have you looked at that yet? Absolutely.
So thank you very much for the question. We haven't looked at this yet, as I have presented just the baseline troponin concentration, and for this specific essay, if I am not mistaken, we just have the baseline. Christian is saying no, so we have more measurements. But I fully think that if it's mainly driven just on the kinetic profile, I would expect that for serial sampling, so at 1 hour and 2 hours, the area under the curve will no longer be statistically significant, will be higher, because if it's mainly driven by the kinetic profile of the early presenters. If we have also seen GFR to be a little bit better, so maybe that could be the reason. We need to look at it, but I would expect more differences just with the 0 hour measurement than with serial troponin.
Last question.
Yeah, thank you for your nice presentation. I am Professor Minaho from South Korea. And I have a question about your diagnostic value, add-on value of CMIC. So you showed the data of ROC curve comparison. And did you perform the reclassification analysis, including IDI and NRI analysis? If we would like to say the add-on superior diagnostic value, diagnostic accuracy, I think you should show the reclassification analysis data.
Thank you very much for the comment, and I couldn't agree more. NRI and ED, as you correctly comment, for reclassification, they are mainly for when you categorize. So in this case, if we had, for instance, and that's the next step, rule out, maybe you're going to comment about the continuous ED, but mainly I mean, we will do this what we will probably see is, when we categorize, mainly, if patients are ruled out or ruled in, we can see the reclassification with the ED and NRI, and this is something that we are looking forward to assess. Absolutely. I mean, yes, but yes, I agree. ED and NRI and decision curve analysis, yes.
Thank you very much, Pedro.